Well, good afternoon, everyone. I'm delighted to be here for the every other month or bi-monthly or every other month meeting with UCSF and NorCal Carsonet. Today, we are delighted to have Dr. Claire Mulvey with us. Dr. Mulvey is a thoracic medical oncologist, UCSF, who focuses on lung neuroendocrine tumors and small cell lung cancer. She trained at UCSF for residency and medical oncology fellowship, where she worked closely with Dr. Emily Bergslin in the GI neuroendocrine clinic. Dr. Mulvey developed a particular interest in neuroendocrine cancers of the lung during a clinical research year at Genentech, where she designed and contributed to clinical trials for small cell lung cancer, which is a disease with high unmet needs for treatment. She joined the faculty at UCSF as an assistant professor in 2021. Her research interests are improving outcomes and improving quality of life for patients with neuroendocrine tumors. Dr. Mulvey, thank you for being with us. We're looking forward to your presentation.
Thank you so much, Lacey, and thank you, Josh. I'm really excited to be talking with you about a disease that's very near and dear to my heart, lung neuroendocrine neoplasms. Hopefully you can see the slides. I'm going to start today with just some brief background about the classification of lung neuroendocrine neoplasms, so we're all on the same page in terms of the language that we use to describe these cancers. Then I'll talk about well-differentiated lung neuroendocrine tumors. I'll focus on some background information, what we know about their incidence and epidemiology, and then I'll spend some time going over the treatment options. I'll talk a little bit more briefly about poorly differentiated lung neuroendocrine carcinomas, but we'll give some background about those cancers and their treatment options. And then lastly, I'll end by sharing some of my research into the epidemiology of lung neuroendocrine tumors here in California. I won't need the full hour, so I'll try to keep an eye on the chat as we're going along, and then there'll definitely be time at the end to answer any questions that folks have. Okay, so by way of brief background, as you're all aware, neuroendocrine neoplasms are quite a diverse group of cancers that arise from neuroendocrine tissues throughout the body. And they can have a really wide spectrum of clinical behavior. If you take any one individual organ, in general, neuroendocrine neoplasms account for less than 5% of the cancers of that particular site. The one exception to that is the lung. They're a little more common in the lung, as I'll talk about in a few minutes. And again, there's this spectrum. So on one end of the spectrum, there are well-differentiated neuroendocrine tumors. These are low-grade cancers that have very good survival years, sometimes even many decades. On the other end of the spectrum, there are poorly differentiated neuroendocrine carcinomas, high-grade tumors, often quite aggressive. They can be small or large cell histology, and the survival for these cancers is much less, on average about 12 to 18 months for folks with advanced disease. Neuroendocrine cancers have a number of different properties, and they're characterized by the site of origin, so wherever they started from, whether or not they make hormones that cause symptoms, their grade, and whether they express somatostatin receptors. Lung neuroendocrine neoplasms have a slightly different classification than neuroendocrine neoplasms for other parts of the body. So I just wanted to start by going over what we call these cancers. So unlike other primary sites in the lung, grade is defined just by the presence of mitoses, which is dividing cells, and necrosis. Ki-67, which is a really important part of the definitions for neuroendocrine tumors for other primary sites, is actually not part of the formal definition for lung neuroendocrine neoplasms, at least not yet. There's interest in trying to harmonize the definitions in the lungs to match other primary sites, but as of right now, that hasn't happened yet. That said, Ki-67 still does have prognostic significance for lung neuroendocrine neoplasms, and so we do pay attention to it. It just doesn't factor into the grade. There are 4 different subtypes of neuroendocrine neoplasms in the lung, which are shown on this slide. Typical carcinoids are the most indolent of these cancers, the most slow growing. These are the equivalent of the grade 1 well-differentiated neuroendocrine tumors in other parts of the body. So typical carcinoids have very few mitoses and no necrosis, and generally have quite a low Ki-67, somewhere in the 2 to 4% range. Atypical carcinoid is the term for grade 2 well-differentiated neuroendocrine tumors in the lung. These are defined by between 2 and 10 dividing cells for every 10 fields that the pathologists look at under the microscope. And there can be small areas of necrosis, but in general, they're quite small. The Ki-67 for atypical carcinoids generally is somewhere between 8 to 18%. Then we have the two high grade 3 neuroendocrine carcinomas of the lung. And there's large cell NECs and then small cell lung carcinoma or small cell lung cancer. These are both high grade 3 tumors. The main distinction here, as the names suggest, is the size of the cells. So large cell, the cells are large, whereas small cell, the cells tend to be small. They have many mitoses, often lots of necrosis, which is sort of dead, dying cells within the tumor as the tumors grow quickly. And there are high Ki-67s. In particular, small cell lung carcinomas, the Ki-67s are often in the 70% or higher range. All right, so I'll start by talking about the well-differentiated lung neuroendocrine tumors. So these are the typical carcinoids and the atypical carcinoids in the lung. And again, this is the unique nomenclature that is really just used in the lung, these terms for grade 1 and grade 2 tumors. If you look at all lung cancers in adults, these are quite rare. So typical carcinoids make up about 2% of all lung cancer diagnoses. Atypical carcinoids are much less common even than typical carcinoids. So they are only about 0.2% of all lung cancer diagnoses. So these are rare cancers. But if you look across all neuroendocrine tumors, the lung is actually a pretty common primary site. So if you include all the different GI tract primary sites together, the lung is the second most common primary site after the GI tract. So 20 to 30% of all neuroendocrine tumors originate in the lung. And there are a few unique things about lung neuroendocrine tumors. So if you think about hormone production, lung neuroendocrine tumors are generally non-functional. So most of them do not make hormones. Occasionally, we do see tumors that make serotonin or its metabolites, so you can see carcinoid syndrome, but it happens much less often than, for example, with small bowel neuroendocrine tumors. There are a few unique hormone syndromes that we do see in the lung, however, so sometimes they can make ACTH, which leads to very high levels of cortisol and a syndrome called Cushing. And occasionally they make a hormone called growth hormone releasing hormone, which leads to a syndrome called acromegaly. So there are a few unique syndromes that we keep an eye out for when we see these patients in clinic. If you look at the molecular features, so these are the genetic features within the tumor tissue itself, we do commonly see particular mutations, including some in chromatin remodeling genes. And then importantly, sometimes there's overlap in the mutations that we see with the mutations we would see in regular non-small cell lung cancers. So in non-small cell lung cancer, we look a lot at the different genetic changes and try to target treatments. Occasionally, we find those same mutations even in lung neuroendocrine tumors. So we always keep an eye. We generally recommend doing sequencing for anyone who has advanced disease. All right, so like other primary sites, the incidence of neuroendocrine tumors in the lungs seems to be increasing. So this is data from SEER that looks across about 4 decades, the incidence of a variety of different neuroendocrine tumors by primary site. And you can see the lung is shown here in gray. This is specifically for lung NETs, so does not include small cell lung cancer or large cell neuroendocrine carcinomas. And you can see there's been a fairly substantial increase in the incidence of these tumors. And the reason for this is really unclear. It is thought that increased detection may be playing a role. So as our imaging techniques, our CT scans have gotten better, as our endoscopic techniques have gotten better, we're picking up cancers that we might have missed earlier. I also think that our pathologists are getting better at recognizing these cancers. In particular, as we've standardized some of the classification systems, I think pathologists may be recognizing these cancers more than they did before, and that could also be contributing to the rising incidence. It's also possible there's something biologic at play, whether it's something in our diet, environmental exposures, medications, some other sociodemographic factor that's contributing. But the driver for this is really poorly understood. And then if you look at survival over time, in particular for lung nets, it's unclear whether we've really gotten better at treating these cancers or not. The data is somewhat conflicting. In general, the epidemiology of lung nets in particular has been pretty understudied. I think part of this is most of the people who focus on neuroendocrine tumors come from a GI oncology background. We know that most lung net diagnoses seem to be sporadic. So there are a few genetic syndromes that are associated with lung nets, but most people who get this diagnosis do not have one of those genetic syndromes. It's not clear whether there's any association with smoking. It seems like for typical carcinoids, there is no association. There may be a weak association for atypical carcinoids, but this is very different than the high-grade neuroendocrine cancers of the lung. So small cell lung cancer, large cell neuroendocrine carcinomas, those are definitely smoking related for most people. And then if we look at what predicts how people do, there's very little that's known. We do know that typical carcinoids tend to do better than atypical carcinoids. Stage of disease seems to matter. So people with advanced disease do worse than those with localized disease. Whether there's any impact of sociodemographic factors on survival is not very well understood. I'll come back to this when I go over my own research, but there's one study that suggests women might do better than men. People who are married might do better than those who are unmarried, and people who have health insurance may do better than those without. But there are a lot of problems in the existing data. A lot of times the low-grade tumors and the high-grade tumors are included together when they probably have very different risk factors in biology. And then a lot of times the lung is included in other primary sites without sort of separating out by primary site to understand what the drivers are of each particular subtype of neuroendocrine tumor. Before I go to the next slide, I think there's a question in the chat. Can we discuss sequencing in advanced lung neuroendocrine tumors and what that means exactly? So this is doing a test to look at the DNA changes that have developed and accumulated within the cancer cells. And we have the ability now to actually read out the DNA codes and determine if there are changes in the cancer cell DNA. We do this a lot in non-small cell lung cancer. Standard of care for folks who have metastases, stage 4 disease, is to do this sequencing and look for particular changes, because we have now a list of treatments, pill treatments that can target each of the specific changes. That is the standard approach for non-small cell lung cancer. Every once in a while for lung neuroendocrine tumors, we find some of those same mutations. And since there are pills that are usually pretty easy to tolerate, or can be easier to tolerate than some other treatments that can target some of those mutations, we always want to know if someone has one of those mutations. So that's an aside going back to one of the previous slides. Hopefully that answers the question. All right, so moving back, I do want to say a word about an entity called DIPNEC. This is diffuse idiopathic neuroendocrine cell hyperplasia. It's a medical term for a rare but probably under-recognized disorder that is a generalized proliferation of neuroendocrine cells in the lungs. So this is a unique diagnosis, it seems, to the lungs, where so there are normal neuroendocrine cells in the lungs, but for some reason they start growing more than expected. And it's thought that it might be a reactive process, so maybe to some sort of irritant or inflammation or scarring. And as the neuroendocrine cells grow, they can block off some of the small airways in the lungs. So on CT scans, there are a few characteristic findings that can suggest a diagnosis of dyspnea. You can see multiple small pulmonary nodules. There's also a pattern called mosaic attenuation, which I've tried to show here in this cross-sectional CT image where there's just different within the lungs, which are normally dark circles. There's areas of whiteness and darkness that vary throughout the lung, throughout the background. And that is thought to be due to, as the small airways get blocked from the growth of these neuroendocrine cells, it affects the perfusion, the blood flow to parts of the lung, and changes the density and the way it looks on a CT scan. So this entity of dyspnea is most often diagnosed in middle age, so in the 5th and 6th decade of life. It is much more common in women than in men. Sometimes it's associated with symptoms, although it can be asymptomatic. So the classic story is a middle-aged woman who's had wheezing and dry cough that can't be explained by other known medical diagnoses, seems out of proportion to anything on her CT scan. And that can sometimes be a clue to this diagnosis of dyspnea. So dyspnea exists on a spectrum. So it's associated with carcinoid tumorlets and neuroendocrine tumors. And in some people, it's thought to be a precursor lesion that can turn into a lung neuroendocrine tumor. And it just depends on whether there's enough growth in the individual cells and if they start invading into surrounding tissue. That determines whether something is a tumorlet, which is a small growth of neuroendocrine cells that's less than 5 millimeters in size, or a neuroendocrine tumor, which is generally bigger than 5 millimeters, and again, has the ability to invade into nearby tissues. So some folks with lung neuroendocrine tumors also have dyspnea as a precursor. However, there are many people with lung neuroendocrine tumors who do not have a diagnosis of dyspnea. So it's a precursor in some, but not all of the patients that we see. All right, I will now talk about treatment. And I'm going to focus on advanced disease. In localized and early stage disease, the treatments are largely either surgery for people who are surgical candidates or radiation, so local treatments. In the advanced setting, so cases where folks can't get all their disease taken out by surgery or radiation, we think about two main goals for treatment, and this is very similar to how we treat neuroendocrine tumors in other parts of the body. On the one hand, we focus on hormone-mediated symptoms, again, a bit rarer in lung neuroendocrine tumors, but we do see them sometimes, and trying to control symptoms is an important goal of treatment. And then we also pay attention to progressive disease, so if cancer is growing or spreading, and the need to stop that with medical therapy. Sometimes, especially for people with typical carcinoid tumors that may have very favorable biology, sometimes watching and waiting is the best option. There are a few unique challenges for lung neuroendocrine tumors. The first is that most of the clinical trials for the treatments that are available for neuroendocrine tumors actually excluded lung primaries from the studies. So there's very little randomized trial data that specifically included lung neuroendocrine tumors. And then, as we see with other primary sites, but I think especially in the lung, there is this very wide spectrum of behavior, even within the well-differentiated group. So there really are some cancers that grow very minimally over decades. There are other lung neuroendocrine tumors that, even though they are well-differentiated, do behave more aggressively. So those are some of the challenges. This slide shows the approvals that we have for neuroendocrine tumors as a whole. And you'll see, like, starting in 1980, in the 80s, we had very few options, but now in the 2000s, and especially in the last 10 years, there have been more treatments approved. We have lanreotide in addition to octreotide as a somatostatin analog. There's targeted pill therapy, everolimus and sunitinib. There's PRRT. Out of all of these treatments, the only one that was specifically studied in lung neuroendocrine tumors and the only FDA approved treatment for a lung NET is everolimus. Everything else we just extrapolate or use retrospective or small prospective study data. There's not randomized trial data for patients with lung NETs. So everolimus in the RADIANT-4 trial was looked at specifically in lung NET. So I'll just briefly go over the data from that study. This was a study it included patients with either non-functional GI or lung neuroendocrine tumors. People were treated either with everolimus or a placebo along with best supportive care. And the progression-free survival, so this is the amount of time people were alive before their cancer progressed in the everolimus group, was 11 months. And that compared favorably with the PFS in the placebo group, which was 4 months. If you look at the response rate, so this is a definition of major shrinkage where people have at least 30% shrinkage in the size of their tumors. The response rates are pretty low. Only 2% of people had a major response. But the disease control rate, which includes stable disease, was higher, much higher at over 80% and better than what was seen in the placebo group. You can see the curves on the bottom of this slide. So those are progression-free survival curves. Everolimus is the blue line, placebo is the red line, and the bottom line is the everolimus group did much better than the placebo group. And so based on this trial, they included lung neuroendocrine tumors. The FDA did approve everolimus specifically for lung NETs along with GI NETs back in 2016. Now, what about PRRT? So Lutathera, a treatment that we use a lot in other neuroendocrine tumors, has not been approved by the FDA for lung neuroendocrine tumors, but it does seem to have activity. And this data comes from a few published small patient series. There's 2 examples on this slide. So there was a trial in the Netherlands that included a variety of primary sites, but 23 patients had lung neuroendocrine tumors who were treated with PRRT. The response rates in that study for the lung NETs was around 30%. And the median progression-free survival was 20 months. The median overall survival was 52 months. And the survival curves are on the right of this slide. The lung group is in blue. And the take-home point here is just overall, it looked like it had pretty similar activity to what was seen for other neuroendocrine tumors like the pancreas or the small bowel. Another study done in Italy looked at 34 patients. About half of them had typical carcinoids. The other half had atypical carcinoids. Similar response rates in the 30% range. The data looked a little stronger for the typical carcinoid group compared with the atypical carcinoid group, but overall, both groups did seem to have good progression-free survival. And it seems like this PRRT likely has activity in the subgroup of patients whose cancers express somatostatin receptors, so the people whose cancers light up on a dotatate scan. All right, so everolimus, PRRT, how do we choose between which one? Well, this is actually the subject of a trial that's being run right now by the Alliance Cooperative Group to try to answer this question of which one should we start with? Most of the time we'll start with a somatostatin receptor like octreotide or a somatostatin analog like octreotide or lanreotide. But after that, what to do next? There's not strong data. So this is a study. Tom Hope, a nuclear medicine physician at UCSF, is the national PI for this study. We are hoping it will be open soon at UCSF, but it's randomizing folks 1-to-1 to either PRRT or everolimus to try to answer this question of which has better progression-free survival, and does it matter how we sequence these 2 therapies? The trial is open now, I think, at 2 sites. So I believe it's open at Memorial Sloan Kettering in New York, and the other site might be the NIH. Currently, there aren't many places where it's open. It's in the queue right now in our activation queue at UCSF. So hopefully it'll be open here soon as well. But eventually, Alliance is this cooperative group of many sites nationally. So there's the potential that it will be more widely available as a study option. And again, specifically, this trial was focused on patients with advanced lung carcinoid tumor. So it really is a lung focused trial, one of the few. All right, atypical carcinoids. I'll just say a quick word about this. I have found personally that the behavior of these cancers is really variable. And there does seem to be a subset of people that have more aggressive disease, disease that can spread into the brain, for example. And in those cases, we do actually use a fair amount of chemotherapy, in particular, if someone has high volume, so bulky disease, or if they have rapidly growing cancer. So we treat the biology, the tempo of disease growth that we see in an individual patient, as much as, if not more, than what the histology shows. And there are a few different chemotherapy recipes that we use. So sometimes we'll borrow from the small cell lung carcinoma regimens, which are platinum etoposide. There is also a little bit of data for capecitabine and temozolomide, specifically in lung neuroendocrine tumors. So we use this a lot in pancreatic nets, but there are some small retrospective and at least one prospective cohort that suggest that there's activity of CAPE-TEM in lung neuroendocrine tumors as well, with response rates anywhere from about 20% up to more than 40%. So it does seem like this regimen has activity, and we use it for lung nets. All right, I'll say just a couple words now about the poorly differentiated lung neuroendocrine carcinoma. So again, these are the much more aggressive versions of neuroendocrine cancers in the lungs. And there are 2 different high-grade histologies. So small cell lung carcinoma is actually far and away the most common neuroendocrine neoplasm that there is. Small cell lung cancer is related to smoking. It makes up about 13% of all new lung cancer diagnoses. And because a lot of people are diagnosed with lung cancer, it's a pretty sizable number of people who get a small cell lung cancer diagnosis. Large cell is rarer, so about 3% of lung cancers are large cell neuroendocrine carcinomas. These are almost always non-functional, so they tend not to produce hormones. And the one exception is sometimes they can make ACTH, which causes that syndrome of really high amounts of cortisol, but most of the time they don't make hormones. They do often cause symptoms, though, and they cause symptoms from cancer growing quickly and spreading. Symptoms like pain, fevers, significant weight loss. These are very aggressive cancers. They are strongly associated with smoking, and they can be very heterogeneous. So what I mean by that is sometimes you can see these high-grade neuroendocrine carcinoma histologies mixed in together with adenocarcinomas and squamous cell carcinomas, all in the same tumor specimen or within the same patient. And that sometimes presents some treatment challenges. I see a few questions in the chat. One person says, I mentioned brain metastases. What are the treatment options for them? I would say there's sort of 3 treatment options, and it would depend on the number of brain metastases, whether they were causing symptoms or not. Sometimes we will do surgery for a symptomatic brain met. We'll have the neurosurgeons take it out. Radiation is also often a good treatment option. So for lower grade neuroendocrine tumors, we'll do focal radiation like Gamma Knife. For these high grade neuroendocrine carcinomas, this is an area of a lot of controversy. The guidelines suggest sometimes doing whole brain radiation because the propensity, the chance of the high-grade neuroendocrine carcinomas of the lung for spreading within the brain are so high that you'll actually sometimes treat the whole brain with radiation. Sometimes though, we'll still try Gamma knife if it's a small number, that's the focal radiation, if it's a small number of metastases. And then lastly, temozolomide, one of the chemo options that we use, gets into the brain really well. So we will sometimes use that chemotherapy in particular if someone has metastases or cancer in the brain. Why is small cell lung carcinoma classified as a neuroendocrine tumor? That's one of the other questions in the chat. It's a great question. It's because it arises from neuroendocrine cells in the lungs. It stains for synaptophysin, for chromogranin. It is a neuroendocrine origin. It's just a high-grade aggressive version in the lung. And again, almost always small cell lung carcinoma is related to smoking. Every once in a while, though, we do diagnose it in someone who does not have a smoking history, but that's quite rare. All right, so what about the treatment for these higher grade neuroendocrine carcinomas of the lung? Well, I'll just talk about small cell lung carcinoma. There are no prospective data for large cell neuroendocrine carcinomas in the lungs. And so the data is very limited about how best to treat those folks, but there's more data for small cell lung carcinoma. In 2022, the standard treatment, frontline treatment for someone who has advanced disease, meaning disease that can't be targeted by surgery or radiation, includes chemotherapy, and we use platinum and etoposide as a combination chemo recipe. And then we add in an immune checkpoint inhibitor. So either durvalumab or atezolizumab. That's the best frontline treatment that we have for this disease. I'll show some of the data on the next few slides for those two regimens. After the frontline treatment fails, so often the response rates are pretty high to the frontline treatment. The challenge, though, is the disease almost always recurs, comes back. And the treatment options in later lines of therapy are very inadequate. So this is a significant unmet medical need. There are different chemos that we use, but if you look at the response rates for any of them, usually it's only about 15% of people who have response rates to neuroendocrine, second line chemotherapy in this disease. The one exception, so lurbinectedin is a new treatment, a new chemo. It got accelerated approval from the FDA for use in the second line for small cell lung carcinoma because in a small trial of about 100 patients, the response rates were 35%, which compared pretty favorably to the historical data. So that's increasingly becoming the second line treatment, but it only is approved in small cell lung cancer. There's no data for any other neuroendocrine carcinomas. Okay, someone in the chat has a question about can typical well-differentiated lung nets that are low grade that have lymphovascular invasion, but moderate to high FDG avidity on a PET scan and then they're wondering if lymphovascular invasion is a risk factor for progression. I mean, I do think we think of that as potentially a risk factor for progression. And then I think they're also getting at FDG uptake. So, sometimes lung neuroendocrine tumors, this is going back to the well-differentiated kind. Sometimes they are avid on a DOTA scan, but not always. Sometimes they light up on an FDG PET scan, so the typical sugar PET scan. And we do think that often there's a spectrum where the brighter someone's tumor is on an FDG PET scan, the more aggressive it might be. That said, it's not always perfect. I think there's a lot of heterogeneity in the receptor expression for these cancers. And ultimately, the most useful information is following an individual over time. And that gives you the most information about aggressiveness and growth. I'm happy to come back to that question later. I don't know that I fully answered it, but hopefully answered part of it. All right, so for small cell lung carcinoma, I'm just going to show the data for the recipe, the chemo immunotherapy regimen that we use as frontline treatment. So this is data from the Caspian trial, which was the phase 3 trial that showed that adding durvalumab to etoposide platinum chemotherapy led to better survival than etoposide platinum chemotherapy alone. We now have data for, gosh, it's almost 40 months for these patients. So it's pretty long-term follow-up for this very aggressive disease. Here, this is a survival curve. So the blue data is the durvalumab plus chemo arm. The red line is the chemotherapy alone arm. And you can see that the blue arm does better. There's higher survival compared to the red arm. And in particular, if you go to the edge of the curve at 36 months, so at 3 years, survival is pretty poor overall in this disease. Historically, it was only about 5 to 6%. Adding durvalumab and immunotherapy to chemotherapy nearly triples the number of long-term survivors. So it's up to 17%. So there is a fraction of people who really improve in terms of how they do when you add a checkpoint inhibitor to chemotherapy. And so because of this, this really has become the standard of care for treatment. Atezolizumab is another checkpoint inhibitor, very similar study. They looked at adding it to the standard chemo. Here, the immunotherapy arm is in blue, the chemo is in red again. And the same general idea, improved overall survival and extended. There's more people living longer with this combination regimen. So that's why this has become the frontline treatment that we use in small cell lung carcinoma. All right, so in the last couple minutes, I just wanted to go over some of my research data that's looking at trying to characterize incidence and survival patterns of lung neuroendocrine tumors in California. This is work that I've done through a Neuroendocrine Tumor Research Foundation grant. The goal of this project is to characterize who gets diagnosed with well-differentiated lung NETs here in California. I'm going to focus really just on the typical carcinoids and the atypical carcinoids. And I was interested in trying to see if there were differences in survival by some sociodemographic factors, in addition to disease and treatment factors. And I was interested in survival differences by sex, race, ethnicity, where people live, so rural versus urban counties. There's a measure of neighborhood socioeconomic status that we use. So it tells you sort of in the area that you live, what's the socioeconomic status of folks in that area compared with the state of California more broadly. Also interested in marital status and insurance payer to see if these factors predicted who lives longer after a diagnosis of a lung NET. This is an observational study. It uses data from the California Cancer Registry. So the CCR is our statewide cancer surveillance registry here in California. It is very comprehensive. Almost all the new diagnoses of cancer across the state make it into this data set. And it feeds into SEER, which is sort of our national cancer registry, and it's a particularly diverse subgroup of SEER. So for this study, I'm looking at adult Californians, so anyone who was living in California at the time of their diagnosis of a well-differentiated lung NET over a 25-year period from 1992 to 2017. And I focused again just on typical and atypical carcinoids that started in the lung or the bronchus. And the main thing I was interested in is looking at mortality and what predicts mortality. I won't spend much time on the statistical analysis, but these are some of the methods that we used to do this work. And I'll show first the demographics. So over 25 years, there were 5,127 cases of lung neuroendocrine tumors here in California. So these are still rare cancers. We found data that was similar to what's been described. So typical carcinoids were far and away more common than atypical carcinoids. So the data in this table, there's number of patients in the percentage of the population. So about 93% of the diagnoses were typical carcinoids. The median age at diagnosis was 64 years. More of the diagnoses came in the most recent decade. So 40% of the diagnoses were made in the period between 2010 and 2017. Much more common in women than in men. And this is really particular for lung neuroendocrine tumors. So 70% of the lung NET population were female, compared with, pretty 50-50 split if you look at California as a whole. And the racial ethnic group of the LungNet cohort was also a bit different. So there were more cases diagnosed in non-Hispanic white Californians. They made up a wider percentage of our LungNet population than the representation in California more broadly. And then in particular, Hispanic and Asian American Pacific Islanders were underrepresented in the LungNet cohort compared with their representation in California. For socioeconomic status quartile, it seemed like there were fewer diagnoses made in people in the lowest socioeconomic status quartile compared with the highest. So 31% of the cases came from the highest quartile. Most people had localized disease, about 2/3. 18% had regional lymph node involvement, and 12% had distant metastases. And then if you look at differences by stage, so are there differences in sociodemographic factors in terms of who's diagnosed with metastatic disease compared with local or regional disease? And the answer is yes. People with metastatic disease tended to be older. Interestingly, they also tended to be diagnosed more commonly in the most recent decade. That argues against the fact that the rising incidence is just due to earlier detection. If we're picking up more cases, but they're also being diagnosed with metastatic disease more often, it kind of goes against the idea that maybe screening alone explains that. So that's interesting. As expected, atypical carcinoid histology was more likely to have metastatic disease compared with typical. There were some differences by race ethnicity. So in particular, non-Hispanic Black Californians were more likely to be diagnosed with metastatic disease compared with other racial and ethnic groups. Same with folks from the lowest socioeconomic status quartile, more likely to be diagnosed with metastatic disease. And then insurance status. So in particular, folks with Medicaid, military, or public health insurance were more likely to have metastatic disease compared with other forms of health insurance. Okay, I'll show just a couple of survival curves. So this is looking over a long time, many years, looking at survival after diagnosis. These are univariate curves. So what that means is they have not adjusted for anything. I'm just showing according to one factor whether survival differed. You can see there were differences in survival by stage. So patients who had distant metastases or an unknown stage at diagnosis had a worse survival over the course of the study period. And same with histology. So atypical carcinoid histology, survival was worse over the study period. Decade of diagnosis didn't seem to matter so much, at least in univariate analyses. Sociodemographic factors also were associated with survival. So women did better than men again, this is just for lung neuroendocrine tumors specifically, but there were differences by sex. There were differences by race ethnicity with worse survival for non-Hispanic Black Californians compared with other groups. Marital status at diagnosis also seemed to influence survival. So people who were married or partnered had better survival than those who were unmarried. County, however, did not seem to be a primary driver. There were not significant differences depending on whether someone lived in an urban county versus a rural county. Neighborhood socioeconomic status did matter. So the people in the highest SES quartile tended to live longer than those in the lowest quartile. And then insurance also seemed to matter with the worst survival for folks with Medicare, followed by military, Medicaid, or public insurance. The insurance data, though, is a little complicated because age plays a big factor in determining, whether someone's eligible for Medicare, for example. So just in these univariate analyses, that is one limitation of the insurance piece. And I think this is my last slide. So this is just the multivariable model. And the idea here is we have all these predictors, things that seem to influence survival when you look at them by themselves. So what happens when we add them all into the same model and we include the treatment that people received? Now, the treatment data in the CCR is pretty limited. They just have yes, no data about whether someone got surgery, radiation, chemotherapy, hormone treatments within the first year after diagnosis. So it's pretty limited. But when you put all these factors together in the same model, many of the predictors still remain significant. So sex still seems to be significant. Women still do better than men. Race ethnicity is the one thing that drops out. So once you start including stage and other predictors, there are not differences in survival anymore by race ethnicity. But marital status, socioeconomic status still remain predictive. Stage is a dominant driver. If you look in the full model, decade of diagnosis, it actually does look like we're doing a better job of treating people. The survival is better for people who've been diagnosed more recently. And then treatment, so getting surgery, people who got surgery tend to have higher chances of survival. Interestingly, radiation and chemo seem to be associated with worse survival. Our interpretation of this data, though, is the people who get chemotherapy with a lung net diagnosis tend to have the most aggressive biology. And same with radiation. So I think that data more reflects the fact that the people who got those treatments had worse disease, as opposed to the treatment somehow contributed to the overall survival. So in summary, from all the preliminary data I've shown, we have shown that beyond just disease-related factors, socio-demographic factors are independently associated with survival for lung neuroendocrine tumors. And in particular, sex, socioeconomic status, marital status, insurance payer, and then some of the treatments that people receive do have independent associations. Race ethnicity was associated with survival in some of the univariate models, but not in the multivariable models. And our hope by showing this data is that, and by doing this research, is we might get some clues about how to do future research to try to better understand the pathogenesis of lung nets. And then we're also interested in trying to find opportunities to come up with interventions to improve outcomes and reduce disparities. And one thing I am now asking more and more and hoping to try to do research to understand is I'm wondering if we're missing some diagnoses, missing lung net diagnoses in vulnerable groups. Again, these are really hard cancers sometimes to diagnose, and people may be getting misclassified as other types of cancers. And it may be disproportionate disclassification depending on these sociodemographic factors. So that's an area we're hoping to continue diving into in the future. All right, and that's all that I had. Okay, I'll just see, I'll try to answer a few of the questions in the chat before we're done. So someone said, how is a sample obtained for sequencing? Can it be obtained from tumors that have already been removed? The answer is yes. So any tissue, whether it's a biopsy or a surgical specimen, can be used to do that sequencing testing. And you can do it on tissue that was collected years ago, as long as the tissue is still around. If someone asks if a lung net has spread, is it necessary to take samples from more than one tumor? How often is sequencing done? That is a great question. That's one of the sort of dilemmas in the field more generally. When in doubt, we have a pretty low threshold to get another biopsy, especially if someone's cancer starts behaving differently than it was before. And the reason why is sometimes these cancers can shift gears. Sometimes these cancers are mixed. There could be more than one histology. So we will sometimes do another biopsy in case there's, to address any dynamic element, like any changes that might be happening within a person or any mixed tumors within a person. And we would consider doing sequencing again if the information might help with our management. Someone asks if there's a typical imaging protocol for these lung neuroendocrine tumors. I would say, so we use some of the same imaging that we do for other primary sites. So we will include a CT scan of the chest in our routine imaging, and then either a CT or an MRI with IV contrast of the abdomen and pelvis. That's kind of the routine screening that we'll do, just really good cross-sectional imaging. If someone's neuroendocrine tumor is avid on a DOTA scan, I will get a DOTA scan periodically, not all the time, but every few years, to keep an eye on sites that are hard to see with regular cross-sectional imaging, like the bones. Not everyone's lung neuroendocrine tumors, though, light up on a DOTA scan. Sometimes the avidity can be pretty weak. In that case, I'll often get an FDG PET scan to see if that's an alternative way that I can follow someone. And sometimes they're bright on the FDG. Sometimes neither PET scan is particularly useful for imaging. So it totally depends on the person and their particular lung neuroendocrine tumor. How well can pathology assure the origin of a NET is the lung? Okay, great question. So for well-differentiated tumors, we look sometimes at markers like TTF1. So these are stains that the pathologist can do of the tumor tissue that can help sort out where it started from. So especially the well-differentiated tumors, we can use the immunohistochemical staining the pathologists do to try to get a clue of where it might have started. And TTF1 positivity in the sample would suggest it might be a primary lung NET as opposed to a lung metastasis. But it can be tricky if someone has multiple lung nodules. For the poorly differentiated neuroendocrine carcinomas of the lung, it actually becomes really hard. These cancers can turn on and off TTF1. And so there's not one perfect test. We can usually help sort out small cells, sometimes by the molecular features, but the primary site can be really hard to figure out. And so we look at the pattern of spread to try to get a clue. Someone asked in terms of the research data that I presented, is this different than what's seen across NETs? It does seem like it's different. In particular, the race ethnicity data does not seem to be consistent in terms of the incidence, at least. There are other researchers at UCSF who are doing similar studies for other primary sites, and we're hoping to be able to compare and contrast our data in the near future. So stay tuned for that. And then someone's asking, is it possible to do NET biomarkers using mass spectrometry? Probably. I have not seen that as a routine test that's done, however. All right, I think I've answered the questions in the chat. I'll give folks one more chance. All right, so another question. Just to characterize, just to clarify, by sequencing, do I mean testing for somatostatin receptor? Is that possible on a pathology specimen? The DOTA scan was done after surgery, so I don't know if it was somatostatin receptor positive. Good question. So this is actually different than just testing for somatostatin receptor on pathology. You know, that's an interesting idea, trying to look at that as a surrogate for whether someone's cancer might be DOTA positive. We don't routinely do that, you know, as a proxy, but maybe we should. Yeah, so it's an interesting, you know, if you get a DOTA scan after surgery and it doesn't show anything, do you know for sure that it's negative, or could it be that there's something occult that just doesn't, you know, your neuroendocrine tumor doesn't express somatostatin receptors? That's an interesting question. Definitely not standard to do the somatostatin receptor staining on pathology, but the sequencing is actually different. So the sequencing, it's a molecular test, so it's DNA sequencing, where you're looking at the genetic code of anywhere from a few to sometimes up to 500 different genes to get a sense for what DNA changes have accumulated within the cancer cells. We don't find mutations that we can target most of the time, but every once in a while we do. And so that's why for someone with an advanced lung NET, we recommend sequencing. All right, do I have any data on COVID outcomes for NET patients? That is a really great question. I do not have that data, but I do think that our cancer center is collecting some data overall and would include different histologies. I know for lung cancer more generally, folks, especially who are getting chemotherapy, do seem to have worse outcomes when they get COVID diagnosis. And then lastly, how can we find out if tumor is available for sequencing if surgery was done at UCSF more than 10 years ago? Gosh, that is a hard question. That might be reaching the limits of what's possible. You could always ask your medical oncologist to to check in with the pathologists to see if they still have the tissue available. I will say that if you ever really needed the information, so if you had cancer that grew back, that would be another time to get more tissue to do the biopsy. Even if they can't do it now, if you ever really needed the information, you could always get another biopsy, even if there was no longer any sample that was collected. There's a question about, do I see the low-grade patients at UCSF? I do. Dr. Gubens is my colleague. I work very closely with him. He is shifting away from lung neuroendocrine tumors, and this is really my particular focus. So I'm taking over the care of at least anyone with a new diagnosis who's referred to UCSF for management. And I see both the well-differentiated lung nets and the high-grade small cell, large cell neuroendocrine carcinomas. All right, why wait and see on a well-differentiated lung net rather than recommend surgery immediately? My surgeon, who I'm glad I listened to, said to cut it out. If cancer's growing in your lungs, cut it out. So I think in general, if you are a surgical candidate, meaning you have enough normal lung that works well enough that you could get a surgery to take out part of your lung and not be left really short of breath. If you don't have other risk factors for surgery, like other medical problems like heart disease that might put you at higher risk for surgery, in general, we do recommend taking out neuroendocrine tumors, especially if they're localized and small, and especially if they're growing. But I think the hard part is there are some people who may have such indolent disease where it may not grow or spread over decades that you might not be obligated to take it out. The reason we sometimes will take it out is to prevent complications if it grew. So that could be recurrent infections, sometimes bleeding. So that's another reason to take it out, even if it's slow growing. But it does depend on the person. So there are some people who the surgery is high risk. And we always try to think about what's the highest risk thing. Is it the surgery? Is it the neuroendocrine tumor? And we weigh all that for an individual patient to try to figure out the best plan. All right, let's see. I did not have an octreotide or a dotatate scan pre-op, but AVID FDG PET. Lung nodules showed up post-op, but were negative on the DOTA. Original tumor, okay. Yeah, so I mean, it sounds like there are a few messages. It sounds like some centers like the University of Iowa may be routinely testing for somatostatin receptor expression by the pathologist to help figure out whether someone's cancer is likely to be DOTA AVID or not. And I think that does make some sense. Yeah, I think that could make some at least intuitive sense. I don't know if there's a lot of data, supporting acting on that decision, but it does make some sense. All right, I think hopefully I've answered all the questions.